So we have a question from Kendall. Could you tell us which material we should study for the midterm? Like we should study Dr. Boylan's material as well?
Just focus in on my 4 lectures. I think if there's plenty of material for research design and statistics, I wouldn't. So there's no need to study Dr. Boylan's or Dr. Gernan. So that first week, and then I think so. Be focused on the research design and statistics. Any other questions? The midterm will be next week. I do apologize for not getting the last week's lecture posted sooner. I had it posted this morning, so it is posted now. If you want to start emailing me 6 o'clock tonight, Jose, where are you at? You can email, and I appreciate actually. So do not feel like you're bothering me. That is my absolute job, but I'm still not in that really good habit of doing it immediately after class, and obviously I want to post today's as soon as possible. I'm running out of off campus today, so I don't think it'll be done immediately or how soon it takes, but I will definitely try to get it this evening, if not tomorrow morning. So the exam will be next week. It'll probably be made available for upload. I wouldn't imagine before maybe even Friday. So still gives you plenty of the weekend to upload the exam. If any problems, we'll be ready to go Monday at 10 o'clock. It'll be 50 questions. It'll be focused on research, design, statistics, so about 25 on design, 25 on statistics, maybe a little bit more on design. So it should be reasonably straightforward, no attempts to trick you. So if you think something is sneaky or tricky, either it's a mistake or you're reading it incorrectly. So it should be straightforward. I will try to make it very fair and try to keep us just moving along because I know you have other courses as well. So we'll go ahead. We'll look at some of the specific statistics that are reported in the literature. And I think I sort of went through this at least somewhat in the last few weeks. There's errors in articles published in literature that shows inappropriate statistical methods are used. And I think about that all the time. I think that's probably one of the coolest jobs to have in sort of the pharmaceutical industry, is because you get to sort of take a body of data and you get to spin it however you like. And I sort of look at it like a chef. A chef's got to be a fun job too. If you enjoy cooking, you take different ingredients and see what you come up with. And to be all honest with you, that's how I feel about statistics. And I'm sure that plenty of people will scream at me, yell at me, throw rotten fruit at me. But I think there's definitely an art to statistics, and there's definitely a science as well. But I think understanding the art and being able to use data available to you is going to help you. It's reported that knowledge of the top 10 statistical tests will provide access to 90% of the statistics used in literature. So just knowing the top 10 tests, which we'll look at, will gain you sort of a key into picking up an article and reading it and having a general understanding. You are not supposed to pick up a biomedical literature evaluation article and fully evaluate the statistical tests used from A to Z of the entire study. That is not what this course is designed. And again, I'm sure that there are statisticians which will argue and fight over this test is more appropriate than that test. There's lots of assumptions being made we looked at last week. So it's to understand the statistics used, why they use them. If there's some sort of glaring problem with that, it should at least raise a red flag. If things are reported that look fishy or incorrectly, to be able to sort of just identify that. Don't worry about not being a statistician. You're going to be a pharmacist. As far as I know, pharmacists make more money than statisticians for the most part, so you chose a good career. There was a study of medical residents, and it looked at their knowledge and interpretation of results of a study. The mean knowledge of a medical resident was about 41%. So even physicians, even pharmacists, even your faculty do not fully appreciate and feel comfortable in statistics. Dr. Eltaki did not, Dr. Gurnant did not, I did not. So it's like telling you that your dad's not as strong as you think that he is. He's probably not as strong as you think that he is. Your pharmacy faculty, at least in pharmacy practice, we don't wake up and know this statistics. I don't bring up a database and I can't just do this stuff without any guidance or instruction. That being said, I do understand double-blind studies, probably 100%. Relative risk, I probably feel somewhat comfortable with that. P-values, I feel good. You should feel good with p-values. You should feel good with double-blind. We'll look at relative risk a little bit more. Today, we'll talk about Kaplan-Meier analysis. At the end of today's class, you should be 100% feeling good about Kaplan-Meier. That's one of those just interesting things that I think it's easy to understand, at least the concept behind it. 75% of residents did not fully understand the statistics. 95% feel it's important. I think I made the point that we're just going to sort of get a good overview of what the top 10 or so statistical tests are. For those of you who took research design and statistics, which I guess is everybody, you should really be even stronger and more comfortable with this at this point, which is wonderful. And that's why I do maintain that I think pharmacists have an outstanding role in the healthcare team. I think pharmacists understand the literature better than other professions. I think we're drawn to the literature. I think when we look at evidence-based medicine, a lot of our practice depends on the literature. So I think having working knowledge is absolutely essential. Having a perfect understanding of statistics, not going to happen. They look at research that had been done. Most studies that are actually published get assistance from a person with statistical expertise. And that's, again, oftentimes Dr. Lai type or actually somebody even stronger with a PhD in biostatistics or in statistics. You go to the pharmaceutical industry when there's a lot at stake about the outcome of a study, they're going to do everything they can with statistics to make sure that they get the most favorable result possible. When you look at statistical tests, this is sort of a good roadmap to why and how you use them. You can compare between groups. I can compare you to last year's biomedical literature evaluation group. I can say one group was smarter. I could say one professor was better. If I'm the better professor and last year's students were the better students, that's not going to be good for you. If you guys are the better students and Dr. Eltaki was the better professor last year, I'm sorry. But I can compare between groups. I can explore the relationship between variables. I can say, if you come to class, you are more likely to pass the exam. Or every class that you missed, you're likely to drop 5 percentage points on the examination. I can say that the more times you watch Tegrity, the higher your exam score will be. I can explore all those variables, and I can determine the probability of an event. I can say, based on your number of times coming to classes, based on your previous grade point average, based on how many times you watch Tegrity, based on how many hours of studying, I can be able to map what your general statistical score is. The College of Pharmacy, we spend a lot of money and time and energy doing assessment of students. We try to figure out which students who score well in the PCAT will score well not only in PharmD school, but on your NAPLEX. We want to get predictors. We want to figure out the probability. We want to explore relationships. We want to compare between groups. How does our new curriculum compare to our old curriculum? So there's 3 different general categories of statistical tests, all of which are very, very useful, obviously, if you can master them. When you look at determining the appropriate statistical test, so we're going to start a study. We're going to look at vitamin B12 versus vitamin C12. Is that what we called it last time? C12? Vitamin B12 versus vitamin C12. We're going to have to figure out what statistical test we want to use. Anybody know what statistical test we want to use? Compare vitamin C12 versus vitamin B12. You may not want an answer yet because we're going to have to look at what type of outcome we're studying. We want to clearly compare between groups. I think that's what we want to say. One drug is better than the other, or are they both equal? The first thing we want to do is identify the data type. That being what? Nominal, ordinal, continuous. If we're saying a cough scale or a cold scale, I feel a little sniffly, I feel more sniffly, less sniffly. Is that going to be nominal, ordinal, or continuous? It's going to be ordinal. Continuous is sort of that predefined, maybe body temperature. If we want to measure body temperature, vitamin C12 versus vitamin B12, we want to see how your body responds. That may be continuous. We want to look at 1 week from now, presence or absence of cold symptoms. Nominal, ordinal, or continuous? Nominal. So we're going to have to identify the data type. We're going to have to look at the distribution. I mentioned last week about 30 subjects is typically a good number to have normal distribution. They have advanced statistical tests to actually be able to tell you if something is normally distributed. We're not going to do that. We're not going to see that. But we're going to have to identify if things are normally distributed or not normally distributed. We'll look at any confounding variables that we may or may not want to deal with. If we're going to look at vitamin C12 versus vitamin B12 for the presence or absence of cold symptoms in 1 week, that's a nominal outcome. We may want to identify and deal with confounding variables. If you have a sick child at home, that's going to confound that study, the presence or absence of your cold symptoms in a week. If you stay at home and you don't socialize with other students, that's going to confound that. You may be healthier. If you have children at home who have a cold, you may be sicker. We're going to look at those variables, identify the number of groups being measured, the two, and determine how those groups are being compared. That seems easy enough. We'll come back to those examples. When you look at descriptive statistics, mean, median, mode, range, and standard deviation. We sort of talked about that earlier. If we're doing continuous data, blood pressure, body temperature, we can do the mean, the median, the mode. The mean is the most powerful, the best statistical test that we can use for central tendency. When we get to ordinal, you can't do the mean. It just doesn't make sense. If you look at how sick you're feeling on a cold scale, 0 to 10, I'm feeling less cold symptoms, more cold symptoms. So we have to do sort of the median of that. Where does it stand within that range? And then if it's nominal presence or absence of cold symptoms, I can't say the median or the mean. I can just say how many people had cold symptoms, how many people didn't say cold symptoms. So just based on the data type, you're limited in terms of how you report things. Standard deviation is going to be for continuous, and the range we looked at can be ordinal or continuous. You can sort of describe, well, let me leave it at that. So what's the preferred measure of central tendency scores on the midterm examination? If I'm going to report that to you, how would you want that reported? Mean, median, or mode? The mean. You want to know what the average is, and you even want to get a standard deviation. If I say that 100 students passed and 30 students failed, and you happen to get a 75, would you rather know that the average was a 90 and 100 students passed and 30 failed, or would you rather just know 130? So again, it's better information to know where you stood. If you just care about passing, that's fine. If you look at type of headache developed during the exam, migraine, cluster, would I report that as mean, median, or mode? It's a mode. I can't do anything saying, the average number of students. It's 6 students got a migraine, 4 of them had a cluster migraine, and then degree of anguish is ordinal, so we're going to be able to look at the median. So very sort of easy. Contingency tables are a way to analyze and document data, particularly for categorical or nominal variables. And it allows us to perform the statistical test to see what the effect of the independent variable on the dependent variable. So your independent variable is your exam scores. Your dependent variable is how many hours you study. The chi-square is the most basic test for comparing nominal data. So if we're looking at the presence or absence of cold symptoms in 1 week, that's yes or no. So we take 50 students with cold symptoms. We give half vitamin C12, half vitamin B12. We come back a week later. We look at presence or absence of cold symptoms. So we could sort of just put it in like that, and we can calculate a chi-square and a p-value. So this is really easy. Here we looked at MRSA. We looked at Zosyn versus Timentin. How many people were cured on Zosyn? How many people were cured on Timentin? How many people failed? Again, you can't, without this here, without this bottom part, you shouldn't be able to look at this and say that Zosyn's better. Statistically, you can't look at this and say Zosyn is better. You can't do that. It was like flipping the coin. If I flip the coin, some Zosyn patients are going to get better, some Timentin patients are going to get better. At some point, I have to say with statistical certainty that Zosyn or Timentin is better. Here I calculated chi-square p less than 0.01. What does that mean? That means that there's statistical difference, statistical significance, and Zosyn is a better drug than Timentin. So just looking at the contingency table, you can't determine that. So if you do a very easy study, you look at drug A versus drug B, you look at outcome or variable A versus variable B, you map out this little contingency table, you can just Google right now chi-square, drop those numbers into a simple chi-square, and it'll literally spit out a p-value. It is that easy. And you can say that my drug is better than your drug. My vitamin B12 is better than vitamin C12. All of the programming of the statistics, we're not here to discuss that today because I don't know how to do that, and I'm not asking you to know how to do that. But I'm asking you, if you set up a study with nominal data that's normally distributed, you should be able to build a contingency table, put those numbers into a calculator, and getting a p-value. What's that? We're not calculating p-values. I can't calculate p-value. That was last semester. Fisher's exact is similar to the chi-square, but it's used when the number is expected to be small. And typically less than 20 or so in total, less than 5 in a given cell. So again, it's just a more exact test. When to use Fisher's exact, when to use chi-square, I'm sure I can get two statisticians in a room and have them literally fighting with each other about where the actual cutoff is. So here we show if you did the chi-square, it would be significant, 0.035. But here using a Fisher's exact, it's non-significant. So just by choosing the right or wrong test, you can show statistical significance or not. So here it looked like drug 1 is better versus drug 2, but the number was so small that you can't provide statistical significance based on those small numbers. Again, you would need larger numbers to get more power to detect a difference if a difference exists. Researchers conducted a study comparing the efficacy of cisplatin versus placebo for the treatment of cancer. The outcome of interest is mortality. What statistical test should be used? Mortality is a nominal categorical outcome data set. Either you live or you die. You could use chi-square. If the number is very small, you may need to use Fisher's exact if you have a small study. Researchers conducted a study comparing the safety of Zosyn versus Timentin, looking at the rate of toxic epidural necrolysis. So here, are you going to have very small numbers in your you may want to do something more exact, like a Fisher's exact, because the risk of toxic epidural necrolysis is small. The next major sort of statistical test, we understand chi-square. The next major statistical test that we use are students' t-tests. Anyone know where the name student's t-test came from? The Guinness beer story. You guys learn that? It's a pretty cool story. So a student was working at Guinness beer and he was trying to figure out the rate of whatever between the two different beers. He was unable to publish anything with his name just based on the Guinness policy at the time, so he used the word student as his name, pseudonym. But student's t-test is another major test that you want to know, you should know. So you've got your chi-square, check, you know that, nominal. You've got your student's t-test, whether the means of two groups are equal. So when we know means, we're talking automatically what type of data set. Continuous. We looked at parametric tests are normally distributed with continuous. So you should remember that from last week. We had parametric tests, non-parametric tests. This is a parametric test. Continuous data, normal distribution, independent samples. We use a student's t-test. We can use a paired student t-test when patients are used as their own control. So sort of a crossover. The data is still continuous, still normally distributed, but we're not comparing independent samples, we're comparing related samples. So chi-square, check. Student's t-test, check. Student's t-test, normal, continuous data. So if we're looking at our cold symptoms, vitamin C12 versus vitamin B12, what would be a outcome of interest that we could use a student's t-test for? Vitamin C12 versus vitamin B12, what's a outcome that we would use a student's t-test to assess the difference? The temperature. So we couldn't use the type of cold symptoms or the improvement of cold symptoms because that's going to be nominal or ordinal, but we have to use that continuous data set, which would be body temperature, blood pressure, number of red blood cells, if we think that the drug is going to impact that. If we use the same student, if we use pre and post, if we're going to use you as your pre, you as your post, we could use a paired student t-test. If we're going to use this classroom here versus Kendall and San Juan and Palm Beach as another group, we compare those groups, we would use the student's t-test. Researchers conducted a study comparing minoxidil to placebo for new hair growth. 50 subjects are randomized to placebo and 50 subjects are randomized to minoxidil. The primary outcome is the number of new hairs grown in 90 days. So we're going to measure, we're going to count all the hair in your head today. We're going to give you minoxidil. We're going to come back in 90 days. We're going to count your hair in your head again. Kind of seems silly. Is that nominal, ordinal, or continuous data? It's continuous data. It's a constant and defined unit of measurement, the number of hairs grown. If you get 3 hairs grown on top of your head and another patient gets 6 hairs grown on their head, they've got twice as many hair that's grown. So what statistical test would we use in that? Student's t-test, assuming it's normally distributed. Very easy. If the study's a crossover study, we're going to use you as your pre, we're going to use you as your post, we're going to cross you over, you would use a paired student t-test. That's how easy this is. That would be an example of a test question. And I will actually use this on the test, so everybody should get at least 2 points on the exam. Now we're going to look at distribution-free tests, which are non-parametric tests, where we don't have normal distribution, or we have ordinal or nominal data. So we're at a less powerful statistical test right now. The first one is the Mann-Whitney U, which is also known as the Wilcoxon rank sum. It's the non-parametric analog to student's t-test, used for ordinal data. What this means, Wilcoxon rank sum, Mann-Whitney U, same test, different names. ordinal data. So we've got our nominal test, which is chi-square. We've got our continuous test, which is student's t-test. And now we've got our ordinal test, which is the Wilcoxon rank sum or Mann-Whitney U. That's very easy. If we're looking at the improvement of cold symptoms on a cold symptom scale, between 0, no cold symptoms, 10, worse cold symptoms, we're looking at the improvement on that cold symptom scale. We can use Wilcoxon rank sum. What gets a little sort of interesting or complicated from a statistical perspective is these tests can also be used for continuous data which do not meet parametric assumptions, which means that it's not normally distributed. So if we're looking at the body temperature, that would ordinarily be continuous, and then we would use a student's t-test for that. However, for some reason, one of the assumptions doesn't hold true, like it's not normally distributed. So for whatever reason, our patients with cold symptoms are not normally distributed in terms of blood pressure or body temperature, then we would use the Wilcoxon rank sum.
So is this the highest sort of standard of test to use for non-parametric?
Right. So for continuous data not meeting parametric assumptions, this is sort of that best test. We can't use the student t-test because the student t-test requires continuous data, requires normal distribution. We can't use that test if things are not normally distributed, so we can use this test. So use for continuous data which do not meet parametric assumptions. For continuous data that's not normally distributed. Equals or arrow sign, you also use this for ordinal data. Because ordinal data isn't parametric. We can't use those parametric tests. Parametric is synonymous with continuous data normally distributed. If you use continuous data, normal distribution, what test do you use? Student's t-test. If you use continuous data not normally distributed, which test do you use? Wilcoxon rank sum. If you use ordinal data, Wilcoxon rank sum. If you use nominal data, student t-test. Wilcoxon rank sum, we looked at that. Wilcoxon signed rank is the non-parametric analog to the paired t-test. So it's that when the subjects are serving as their own related samples. So paired t-test, Wilcoxon signed rank. You've got your Kruskal-Wallis rank sum test, which is the non-parametric analog to the ANOVA, which we'll look at the ANOVA. ANOVA, 3 or more groups typically that are looking at continuous, normally distributed data. Researchers conducted a study comparing the efficacy of pregabalin to duloxetine for the treatment of diabetic neuropathic pain. The primary outcome is change in visual analog pain scale at 24 hours. So you give patients with diabetic neuropathy, you give it to them pre, you give it to them after the drug. Half of them are randomized to pregabalin, half of them are randomized to duloxetine. Which test are we going to use? Is this nominal, ordinal, continuous data? It's ordinal, so we're using the Mann-Whitney U test. Now we're putting a third drug in there. You can put a placebo in here, or you can just use Zicam echinacea placebo. Same type of scale, ordinal scale. So rating 0, I have none, 1 mild, 2 moderate, 3 severe. Is that a constant and defined unit of measurement? No. Therefore, it's not continuous, it's ordinal. Which type of data is being used? It's ordinal. What statistical test would we use here? If it was continuous, it would be ANOVA. It's non-continuous, it's ordinal, so we use the Kruskal-Wallis rank sum test. So if you set this study up, which is something that you very well may do this year, next year, P4, graduation, residency, setting up a study, I'm looking at 2 different drugs for diabetic neuropathic pain, or I'm looking at 3 different products for, this is ordinal. And for 3 groups, we would use the Kruskal-Wallis rank sum test. For 2, we would use the Wilcoxon rank sum test. ANOVA compares the means of 3 or more groups. We looked at that to determine if the mean of one group differed from those of another. We established this last week. You can't just look at the data set and say, yes, this product is better than that product, or this one is better than those 2, or these 2 are better than that one if you're looking at 3. You have to do statistical tests. You have to apply the F statistic when you're doing ANOVA. We'll come back and explain this as we go along. There's something called the Bonferroni correction method for reducing the overall risk of a type 1 error with multiple comparisons. If you're going to do 3 groups, say placebo versus atorvastatin versus lovastatin, placebo, atorvastatin, lovastatin. I do a study, all 3 of those. I get differences. Atorvastatin looks the best. Lovastatin is pretty close. Placebo, much less. At what point do I say with certainty that atorvastatin is better than lovastatin? At what point do I say that lovastatin is better than placebo? At what point do I say atorvastatin and lovastatin are equal? I'm doing 3 individual tests, if you can understand that. I'm sort of comparing atorvastatin versus lovastatin and placebo. I'm comparing lovastatin versus placebo. So I'm doing all these different tests. What I can do is do a simple study of that type. I can keep just comparing A versus B, A versus C, B versus C. I can do those 3 different types of analysis. And I can use what's called a Bonferroni correction when I just take the alpha and divide it by the number of tests, which in that example would be 3. I'm comparing placebo versus atorvastatin, placebo versus lovastatin. I'm comparing atorvastatin versus lovastatin. And then if I want to compare atorvastatin and lovastatin versus placebo, the different combinations. We'll look at the example. Multiple comparison test is another way to do it. You do the ANOVA, you get a result, and then you have to do a post hoc to figure out where the difference lies. So oftentimes, you don't use a Bonferroni correction because every time you divide that 0.05 by a smaller and smaller number, it gets harder and harder to detect the difference. You're going to need more extreme differences. So what they do is they run an ANOVA, you get a significant F test. Okay, there's a difference. One of them is different from the others. And now I have to go back and figure out which of those. If it's atorvastatin is better than lovastatin and placebo, or if atorvastatin and lovastatin are better than placebo, or there's no difference. We would have to sort of go back and look at those. So the example is, researchers conducted a study comparing captopril, diltiazem, metoprolol, and losartan. So you've got 4 different drugs I'm comparing in patients with hypertension, nominal, ordinal, or continuous. How many people say ordinal? Hypertension, well, blood pressure. Sorry, okay. So it's continuous data. If we were just comparing captopril versus diltiazem, what test would we use? Student's t-test. If we're doing now, we got 4, what statistical test do we use? The ANOVA. So 3 or more groups, continuous, normally distributed, I use ANOVA. What statistical test should we be using? ANOVA. If we were using Bonferroni correction, so we've got captopril versus diltiazem, so 1, we got 2, and 3. So captopril versus diltiazem, metoprolol, and losartan. We've got diltiazem versus metoprolol and losartan. So we've got 2 more. 3, 4, 5, and now we're comparing metoprolol to losartan. So we've got 6 different comparisons, essentially. So if we were using the Bonferroni correction, we would use 0.05 divided by 6, which is 0.00833333. So if we were using a Bonferroni correction, we could do that, but we would need the alpha at 0.083333 for each of those comparisons. It's very hard. So it's that probability. So I multiply that times 100 if you wanted to. It means that 0.83. So I have to be over 99% certain that that drug is better than the other drugs for each comparison. Okay.
For this kind of study, would you correctly use a surrogate outcome, or would you use a primary outcome, like mortality? How would you test for that?
Right. So again, that's getting to study design. The actual mortality is probably a better outcome, but we're not going to be able to study that during our residency when we want to compare 4 drugs on the impact of blood pressure. So if we use Bonferroni correction, that's going to be very, very hard with our number of subjects to detect if these drugs are different. So we would sort of do an ANOVA, a one-way ANOVA. We would calculate that F statistic, and then we would use one of these post hoc analysis to determine which of those were different. So we've got, say, a p-value or an F statistic that shows statistical significance, and now we could do any one of these. I don't know the difference between any of these 4 beyond what's written here. And if you catch any one of your faculty member in the hallway, you may ask them, why do you use Tukey's versus Dunnett's? And I'm sure every faculty member in the Department of Pharmacy Practice will shrug their shoulders. Again, this gets back to sort of which test. I'm going to say this test versus that test in this situation. But understand why you do a post hoc comparison. Because if you try to just compare all of these 4 drugs in 6 different ways, it's going to be so difficult for you to detect a difference. So you use the F statistic, you use the ANOVA, you calculate a difference using a post hoc comparison. Any questions? It shows that after you get a significant F test, so you put these 4 in, you get an F statistic that shows there's statistical difference. Now you have to know which of those drugs is different from the other ones, or which of those 2 is different from the other ones. So at that point, you're doing the post hoc to see which drug is different from the others. Did that answer your question? So here, ANOVA, if we're using Bonferroni correction, would be what, 0.008333. That would be your alpha. What procedure can be done if a significant difference is detected? You may use any of these Chef's, Tukey's, Dunnett's, or Fisher's test. 2-way ANOVA to determine the effects of 2 factors on a dependent variable. So now if we want to look at the drugs and we want to look at maybe age on blood pressure. Do younger individuals respond better to any one drug? Do older individuals respond better to a different drug? If we're going to look at the effect of 2 factors, 2 independent variables, age and drug on a dependent variable, we would use a 2-way ANOVA. And the ANCOVA used to control the effect of an influencing variable, a covariate. It's a lot. I tried to keep it simple. Again, my whole goal is for you to pick up an article and you see 4 different drugs and they report that they're doing 4 different sort of tests using the Bonferroni correction, it doesn't show statistical significance. You may still say, whoa, maybe there's a difference, but this was just too hard a challenge. Maybe they could have used a post hoc. Or maybe this test was just too much to bite off. I can't imagine that any 4 of these manufacturers would want to do this study, because chances are they're not going to show that they're better than the competitors. So just understanding sort of research design, or if one of these did do this study and they showed they're better, that's a huge uphill battle, a huge uphill to climb. You know, maybe that losartan, if it did show that they were better, that's a huge landmark finding potentially. So it's just that sort of evaluation of the literature. The next thing we'll talk about is relative risk. We looked at this a little bit earlier. We use this for case control studies or cohort studies. Cohort. It's prospective study design, observational. We're looking ahead. Odds ratio is used for that case control. So the prospective, the relative risk. The epidemiologic measure of disease frequency. What's the risk? How many people here eat broccoli? What's your relative risk of getting cancer versus those who didn't raise their hand? Do you have a lower risk of getting cancer than those who don't eat broccoli? If you have a relative risk of 1 compared to those who don't eat broccoli, do you have a higher risk or a lower risk? For those of you who eat broccoli, you have a relative risk of 1 compared to those who don't eat broccoli. Do you have a higher risk of cancer or a lower risk? Relative risk of 1 means the same risk. So you have no difference in risk. For those of you who eat broccoli, you have a relative risk of developing cancer of 0.5. Do you have a higher risk of developing cancer, a lower risk, or the same risk of developing cancer? You have a lower risk, 0.5. If the risk was 1 relative, that's the same risk. Anything more than 1 is a higher risk. Anything less is a lower risk. So 0.5, somebody mentioned it here before, that's a 50% risk. That's a 50% risk reduction, a 50% relative risk reduction. So for those of you who eat broccoli, have a relative risk of 0.5 compared to those who don't eat broccoli, have a lower risk. For those of you who eat broccoli, have a relative risk of 4 compared to those who don't eat broccoli of developing cancer. It's a much higher time, 4 times higher, of developing cancer. So maybe there's something with the pesticide, or maybe broccoli triggers a certain type of cancer. But understand what relative risk is. If my risk is 1 relative to your risk, it's the same risk. If my risk is 1 relative to your risk, we have the same risk. If my risk is 2, I have a twice as high risk, 100% increased risk. If my risk relative to yours is 0.1, I've got a 0.1 relative risk. I've got a much lower risk, a 90% lower relative risk compared to your risk. A 0.1 would be 90%. So statistically significant if the 95% confidence interval does not contain 1. We sort of looked at that. The best way to do that is to work through examples and look at those. So relative risk, less than 1 decreased risk, greater than 1 increased risk. Relative risk of 1 is the same risk. Relative risk of 1.15 means a 15% increase risk. This is how you do observational cohort studies. I calculate how many patients eat broccoli, develop cancer. How many patients who didn't eat broccoli develop cancer. I calculate a relative risk. I interpret that relative risk. The same thing I can do in a case control study. That's a retrospective looking back. that is associated with an odds ratio, the epidemiologic measure of effect size. So if I have an odds ratio of less than 1, lower odds, greater than 1, increased odds ratio of 1, same odds, anything greater than 1, 1.15 means a 15%. So it's just sort of a different denominator. And the mathematics behind this, I don't want to sort of get hung up. But understand that the odds are you being exposed to something. You developed cancer now. What were the odds that you ate broccoli versus you didn't eat broccoli? That's different than looking at what percent of patients who eat broccoli versus don't eat broccoli develop cancer. So it's an entirely different window, a different prism that you're looking through. And when the odds ratio, I can look at patients who smoked, what would be, or patients with lung cancer. What were the odds that they smoked? If you had an odds ratio of 1.15 smoking versus non-smoking developing lung cancer, is that a higher odds that you smoked or a lower odds that you smoked? It's a higher odds. It's a 15% higher odds. So in that study, I can look back at patients with cancer, how many of them smoked, how many of them didn't smoke. I can say that smokers had a 15% higher odds, or patients who had lung cancer had a 15% higher odds that they also smoked. And this is the way you do it. The exposure, ate broccoli, didn't eat broccoli, smoked, didn't smoke. How many of you developed cancer, didn't develop cancer? How many people didn't smoke or didn't eat broccoli, developed cancer? Or developed cancer, didn't develop cancer? So again, it's that very simple table, and then that's just how it works mathematically. That's how it looks. So it's that different denominator. You're taking into account those who had the outcome and those who didn't have the outcome. Versus here, we know the patients have cancer. How many of them smoked? We know that they had cancer. How many of them smoked? Here, it's how many of them had cancer and didn't have cancer, ate broccoli, or smoked. So it's a different denominator. Prospective cohort, same sort of general evaluation, general interpretation. If it's less than 1, it's a lower risk. If it's higher than 1, it's a greater risk. Lower than 1, lower odds. Higher than 1, greater odds. Researchers followed physicians taking aspirin and those taking placebo to determine who had an MI. Placebo versus aspirin, those in MI, you want to calculate a relative risk reduction, number needed to treat. If we were looking how many patients had an MI, and then we look back saying how many of them took aspirin versus didn't, we would look at the odds. Here we're looking at a prospective study following physicians taking aspirin versus those taking placebo. We determined 1.3% had an MI on aspirin, 2.2% had an MI on placebo. You can calculate a relative risk. You can calculate a relative risk reduction, an absolute risk reduction, and number needed to treat. Well, go ahead. You can work that out either during the break or next week. You can email me. We will take a 10-minute break, and we will come back, pick up with correlation. All right, any questions about the first hour's material or the content to date or about the midterm examination?
Christina, we have a question here from Kendall.
Okay, what's your question?
What would be the best way to prepare us for this part? Because, I mean, it's a lot, and I know that we already sealed this with the stats, but honestly, we don't remember anything.
I think the best way to sort of study is just to go through the slides. I mean, honestly, there's very little material, at least in that first hour. despite what anybody wants to think. If we look at ordinal data, comparison between two groups, what are we going to use? Ordinal data, comparison between two groups, what are we going to use? The Mann-Whitney U, the Kruskal-Wallis. Well, I would tell you just to go through the notes. I'm trying to keep it as simple as possible. The exam, I'm trying to keep it straightforward. Again, I think this stuff is important when we look at something like correlation. My goal, again, is not to have you actually perform the analysis, but it's the interpretation, the reading of it. So, what I always say for all my exams is just to go through and look at sort of the topics. When we look at Bonferroni correction, do you understand what that is? If we look at the ANOVA, do you know that that's for 3 more groups? If we looked at the Wilcoxon-Sign rank test, do you know what that is? If we look at a contingency table, do you understand what that is? If you look at categories of statistical tests, do you understand the 3 categories? If we look at number needed to harm, would you be able to calculate that? Things like that. I think just the topic headings, understanding what they are. So understand what a student's t-test is, what the paired student t-test is, how they're different. Here's an example. Understand that distribution-free tests, they're non-parametric. Wilcoxon ranks some, Wilcoxon sign rank, Kruskal-Wallis ranks some. So it's like studying for any other test. Again, I apologize that I can't give you, but I'm trying to sort of help the best I can.
Think we have to just review our statistics class last semester.
I'm not going to comment on that. I'm not going to give you that advice, but if it helps you, right. Okay. Again, this is 1 hour out of at least 8 hours worth of material. So you should understand this research design, understand what double-blind studies are, controlled studies, cohort studies. Correlation, a measure of the strength of the relationship between variables. When you look at the correlation, they typically report a correlation coefficient. Ranges from +1, perfect positive correlation, to -1, perfect negative correlation. Typically, you're not going to see perfect correlation with anything because there's other variables, confounding variables, covariates. There's lots of different things that can interplay. But when you see something close to 1, you know that there's a positive correlation. When you have that, you're going to have that outcome. You're going to see a negative correlation. If you have that, you're not going to see that outcome. So the closer you get to +1 and -1, the greater the correlation. Correlation is the strength of the relationship between 2 variables. Your null hypothesis is basically saying that there's no difference, no relationship between variables. So when you then do a correlation coefficient, you can get a positive or a negative. So here, as A goes up, as the X goes up, you see the Y go up. So as one goes up, the other goes up. This is probably very close to what correlation coefficient? A +1. It's almost perfect. So if you go up by 50%, this is going to go up by 50%. You go up by 80%, that's going to go up by 80%. Here you see another, looks like positive correlation. As one goes up, the other goes up. It's not perfect as a perfect line. It's a little bit more scattered. So this may be 7, 0.7. Again, it's just understanding, and this will be a test question as well, most likely. You can just read this. Understand that if this is the number of days and this is the number of cancers, as the number of days go on, the number of cancers goes up. As one goes up, another goes up. This one, as one goes up, the other goes up. Is that going to be a positive or negative correlation? Positive. Here you see what type? A negative. Here you see what? I would say maybe a 0, a negative, a slight negative. Here looks a little bit more random to me, and this is no correlation. So typically, they report it as weak to no correlation, moderate, good, very good, and probable, excellent correlation. So again, when you see something like 0.9, you're going to see something like that. That's excellent correlation, probably predictive. What you do is you take the correlation coefficient, the R value, and you square it, and it gives you what's called the coefficient of determination. And because you're squaring something, you're going to get from 0 to 1. In that example, you are squaring anything from 0 to 1. When you square that, you're going to get a 0 to 1. Or it's -1 to -1. So this is just strictly a squaring of these numbers, positive or negative, and you get the coefficient of determination, which is that goodness of fit. It approximates the amount of variability of one variable to be contributed to another variable. So it sort of allows for some differences in those variables, those covariates, those discrepancies. Once you square that, it gives you a tighter fit. We talked about this earlier, that correlation is not causation. Up in Maine, as the summer months, you've got more drownings, or you've got more number of ice creams. As the number of ice cream sales increases in the summer in Maine, you've got more drownings. Does that mean that the more ice cream you eat, the more likely you are to drown? No. Completely not the causation. But they're correlated. What's the correlation between the number of ice cream sales and the number of drownings in Maine? Is the months. More people are summer, they're eating ice cream, they're also swimming because it's summer, they're at the beach, more people. But understand that that is not causation. So when you get correlation and you get coefficient of determination, that's wonderful. We know that the number of ice creams increases, the number of drownings increases. There's a correlation, but there is not a causation. So you can't then say, oh yeah, we're not going to sell ice cream in Maine in the summer, we won't see drownings. That's not the cause, it's the correlation. But it allows you then to understand that when ice cream sales start to peak in Maine for whatever random month, maybe in November, it's a very warm month, a lot of people buy ice cream, maybe then the city or the state knows to maybe put more lifeguards on duty because there is a correlation. There is not a causation. Regression is the degree to which one variable changes in relationship to the other. So here we know as one goes up by 50%, the other goes up by 50%. Here it's a little bit less clear in terms of what the amount is. So we can actually perform regression to show as one variable changes, what's the other variable going to change. So we can figure that out, the number of hours you study. We assume that there's a positive correlation. The more hours you study, the higher you will score on the exam. Ideally, it would be 1.0. If you study 10 hours, you'll get 100. If you study 9 hours, you get a 90. If you study 8 hours, you get 80. But we don't have perfect correlation because we have other variables based on what your IQ is, based on how you study, based on whether you came to class. But we can also sort of conduct regression, the amount of one variable changes in terms of the other. And we'll look at that. When we look at regression, there's also 4 different types. There's linear regression, which is the straight line relationship. Nonlinear, when the relationship is exponential. Logistic, when the outcome is categorical, like pass or fail. And multivariable, which we take multiple predictors. So what your PCAT score was, how many hours you study, what you scored in your research design and statistics. I can put all that in, I can calculate a multivariable regression. So if you studied 10 hours and you got an A or a 90 in research design and statistics, and you scored a 10 on your PCAT, I forget what PCAT, 100% on your PCAT, then you, by regression, will score 100 on the midterm exam. If you scored an 80 on research design statistics, you had a 50 of your PCAT, you studied 6 hours, I can be able to calculate what your exam score will be. Or I can look at sort of just will you pass or fail based on logistic. It's a categorical outcome. Linear would be when there's a straight line relationship, nonlinear when the relationship is more exponential or quadratic. So the more hours you study, it starts to take on a higher peak or a lower peak. If you study for 5 hours, you're going to get a lot of points. Every hour you study thereafter will give you a smaller number of points. You have less of an increase. So it's not going to be a linear regression. Here's an example of a study in a multivariate logistic regression analysis. Metformin monotherapy was associated with reduced mortality. So they looked at metformin mortality compared with sulfonylurea after controlling for age, sex, chronic disease score, and nitrate use. So in some regard, this is a much better study than just looking at metformin versus sulfonylurea for mortality. Because we may find out that metformin is better than the sulfonylurea for mortality. That's good information. But if we can actually control or see what the influences of age and gender, male versus female, how long they've had the disease, how sick their diabetes is, are they taking nitrate use or not? All of that is going to be better information for you as a practitioner, as a clinician, to then determine whether you should use metformin monotherapy or compared to sulfonylurea. Another area of statistics are called life tables, statistical procedures for data where the outcome of interest is time until an event. For those of you who are interested in buying life insurance, there's what's called life tables. They figure out an actuarial method to determine how much to charge you. If you're 80 years old and you buy life insurance, it's going to be expensive. If you're 20 years old and you buy life insurance, it's going to be inexpensive because they calculate what the likelihood of you dying over the next 20 years, 30 years, 40 years, 50 years. And then they calculate a cost based on that, based on what the market's going to do, how much money they're going to get from you, how much money they're going to pay out from you, what their percentages are. You can also use a Kaplan-Meier curve. And a Kaplan-Meier curve is a statistical procedure where data is reanalyzed or analyzed each time an event occurs. And let me show you an example. Researchers conducted a study to determine how long 6 patients lived following heart transplantation with a new immunosuppressant. So I've got 6 patients in my hospital. They all had heart transplant. I'm going to give them a new immunosuppressant. I want to see the likelihood that they will live over a period of time. I'm not seeing if the drug works or doesn't work. I'm not comparing. I'm calculating a Kaplan-Meier survival analysis. How long will patients live on the immunosuppressant over time? I can also do a comparator versus standard therapy, calculate another Kaplan-Meier curve, and compare those. But again, if I show you a graph and it shows 2 curves, can you make any statistical certainty, statistical decisions based on looking at those 2 curves on a graph? No, you need that p-value, that other information. But let me show you what this looks like. 6 patients, heart transplantation. In study number 1, patient number 1, they lived for how many weeks? Say 5 weeks. Patient number 2 lived for how long? At least 12 weeks, which is great because we don't know, maybe they lived 13, 14, 15, 16. they live for 12 weeks. Patient C, patient number 3, survived how many weeks? From about 3 to about 6. So 3 weeks. And then what happened? They lived, they died? We don't know. So we have to sort of figure out what to do with that data. That's called censoring that data. They may have died, they may have lived. We don't know. Patient number 2 survived for 12 weeks. And then what happened? We don't know. We censor their data. Patient number 4 started at week 4 and made it till week 12. They lived for 8 weeks, and we have to censor their data, which is different from patient A, which we know lived for 5 weeks on that immunosuppressant. Patient E started at week 3 and went to week 10. We have to censor their data. After 9 weeks, we don't know what happens to them. Patient 6 started at week, 7, went to week 11, so 4 weeks, and they died. In some statistical manner, this is better for us because we know what happened. We know how long they live for. But these patients, we don't know how long they live for. So we have to, what we call, censor their data. So uncensored data is data on patients to whom the event has occurred. It's uncensored. We know everything about those 2 patients. They live for 5 weeks, they live for 10 weeks, they live for X number of weeks. Censored data, data about patients who have not yet experienced the event. Either the study is stopped, something else happens, they're lost to follow-up, we censor their data. Kaplan-Meier survival analysis is a statistical approach to calculating the probability of experiencing the event over time. So now we take these 6 subjects and we look at the 7th subject. And we have to calculate about how long they're going to live over time. If it was an actuarial method, we would be able to use all the data that's available. We would be able to have uncensored data. We would be able to have complete data on patients. But when we do a Kaplan-Meier curve, we have to censor our data. We have to use data that we don't know about. And that's what a Kaplan-Meier curve is. It's a statistical plot of survival analysis calculating the probability of experiencing an event over time. This is one of those things I memorized my first year working here, and it has stuck with me. Anytime I see Kaplan-Meier survival analysis, it's the probability of experiencing an event over time. And this is what it looks like. The likelihood of surviving over time. Cyclodepine versus aspirin. At 600 days, what's my chances of living, or proportion of patients who live at 600 days on cyclodepine? I got about 14.14. 14% of patients live, or whatever, proportion of them survive at 600 days. Is aspirin a little higher or lower? It's lower. You've got a lower proportion of having recurrent stroke, MI, or vascular death. Can you look at these and see a difference? You have to go then to the log rank, which gives you your p-value. So the log rank test is used to compare survival curves and determine statistical significance of the data. So here, cyclodepine looks better than aspirin. However, is it different? P-value of 0.12. There's no difference. Because we use p-value of what? The probability value. 0.05 as our alpha, our threshold. So here, cyclodepine and aspirin look a little bit more divergent. There's a greater difference. So cyclodepine looks better than aspirin on recurrent, fatal, or non-fatal stroke. Is it statistically different? 0.08. No statistical difference. So you look at this. This is a Kaplan-Meier survival curve. The probability of experiencing the event over time. The probability of experiencing stroke, MI, or vascular death. or the likelihood of experiencing fatal or non-fatal stroke over time. So we just use statistical methods to calculate a probability survival analysis, and we calculate the p-value, which shows no difference. Used to measure a dichotomous endpoint over time. So it's that nominal categorical endpoint. So Kaplan-Meier curves are very easy. You'll see these in almost every study now. Every major study published in a major journal will calculate the experiencing of probability over time. Cox proportional hazards is the same thing as a survival analysis. However, it gives you the treatment effect after adjusting for other explanatory variables. So here we just looked at ticlodipine versus aspirin on recurrent stroke, MI, or vascular death. If they also took into account age, gender, the disease, how sick were they, then you would calculate out a Cox proportional hazard, which would be reported as a hazard ratio. And this is sort of a good example of what that looks like. In addition, we did all these looking at beta blockers on outcomes. So the likelihood of experiencing the event over time. Here it was a negative outcome over time with beta blockers. Covariates included randomizable VTAC. Did they have VT? How old were they? What their gender was? What their race was? What their ejection fraction was? What their duration in beats was of the longest episode of non-sustained VT? The number of vessels with high number of stenosis, history of MI, prior thrombolytic therapy. Did they have a left bundle branch block? Did they have intraventricular conduction delays? Did they use digitalis at baseline? Was there prior bypass surgery or angioplasty or symptoms of angio within 6 months, 6 weeks? So they did all of these. They took into account all of these variables, and then they calculated out a difference. So for you, if interpreting this, there's a lot going on right here for you to interpret. You know, one, this in theory sounds good. They're controlling for all of these using statistics. But again, if one of these is poorly designed for, poorly considered, then the whole variable falls apart. You know, would you rather sort of each of these broken out, or do you appreciate this because, you know, these patients on beta blockers often have a lot of these covariates? And here they showed the risk of experiencing the event over time. So at 5 years, beta blockers were here, no beta blockers here. Say the event was death, who had a higher death rate at 5 years? No beta blockers. So maybe 0.5, so 50% of patients died without beta blockers, 30% of patients died, 30% of patients died with beta blockers, 50% of patients died without beta blockers. So we could see that. Here they controlled for all of these variables. So when they adjusted it, you see a 0.0001, which is a huge difference. And 95% confidence that the real difference falls within this variable. But for unadjusted, there's also a statistical difference, which shows that beta blockers work just without adjusting for all those other variables. And again, a very small probability factor that it was due to chance.
Why is the unadjusted p-value and the adjusted p-value the same?
That's just the way the statistics worked out. It's showing that just the math that the beta blockers were much better than no beta blockers. That's just based on their use of this data. They plugged in all of this data for all of those patients, and that's what calculated out your log rank test or your p-value.
So there wasn't that many confounding variables.
Again, you can right. So at the end of the day, the beta blockers was the most important sort of variable, is what they're saying in the study. Research conducted a study comparing the effects of TPA versus angioplasty. So you've got drug versus surgery in patients with an MI. A bypass versus the clot buster. The primary outcome was the composite of death, reinfarction, or stroke at 30 days. We spoke earlier, I'm not personally a fan of these composite endpoints. I'd rather them all teased out separately. Here they did primary outcome, the composite of death, reinfarction, or stroke. What statistical model is used to measure survival? So to measure survival, you've got your Kaplan-Meier survival analysis, the probability of experiencing the event over time. So what's your probability you're going to get death, reinfarction, or stroke at 30 days? What statistical test is used to determine statistical difference? So that's your log rank test, which is going to give you your p-value. So again, I want to sort of go back. Looking at these, they calculate using a log rank test will give you your p-value. So on the exam, if you see tyclopidine versus aspirin, you're going to have to know that they use a log rank test, and you're going to have to look at the p-value to see if there's a difference. The probability of experiencing the event over time. Here was 700 days. Here the probability of experiencing that event was the recurrent fatal or non-fatal stroke. And what statistical model would be used to include the effect of smoking and gender as predictor variables? So now we want to know, how is TPA, the drug versus the surgical bypass, which of those is better at the end of 30 days on the composite outcome of death, reinfarction, or stroke? I'm also going to compare for patients who smoked and didn't smoke, and versus male versus female gender. And I'm going to get this result. The Gusto 2B study was a landmark study. Composite endpoint was 9.6 in the angioplasty group and 13.7 in the TPA group. Freedom from composite endpoint. So this is the likelihood of not having an event, essentially. So at 0 days, you already had a few people who essentially had passed because either the drug or the bypass. But what happens after 30 days? About 86%, 87% of patients on TPA survived, and about 90% of patients on angioplasty survived. Which of these which of these interventions had a better outcome? Angioplasty or TPA? Angioplasty. Is it statistically significantly different? You have to look at your p-value. Is it less than 0.05? Yes. So here we know that angioplasty was better than TPA in the Gusto 2B study. You can also look at the odds ratio, which this study happened to do, that the odds was 0.67. The odds of survival, the difference, 95% confidence interval, was 0.47 to 0.97. So either a very small difference or a much greater difference. Here they had the odds of being sort of at 2/3 that patients would survive more often than on the angioplasty than the TPA. So this is just, again, illustrative. I'm not asking anybody to calculate, well, you may be asked to calculate relative risk reduction, absolute risk reduction, and number needed to treat. That should be easy. You should be able to calculate that. Beyond that, it's just a question of, can you understand, if you were shown this graph in the study, can you tell which of these is better, no beta blockers or beta blockers? So here the event, you had a higher event rate on no beta blockers, and you see the p-value of less than 0.05. I know it's a lot, but I think once you sort of just sit down and you break this out and look through the examples, if you go through all the examples in the class, in the notes, I think you'll be more than fine. Because none of this is difficult. But it does require you to have a general understanding, a philosophical understanding of what statistics is used for, how it's used, and why you're using it. Yes. Yes. Exactly. So again, you can't make any statistical determinations here based on this at 2 years. You could run a log rank test and get a p-value at 2 years. You can do a log rank test at 1 year, get a p-value, but they didn't. So even if you measure it with your fingers, this is the same as this, you can't say with statistical certainty. And that gets back to that flipping of the coin. You don't know at what point statistics is saying, okay, now there's a difference. But we do know at 5 years, with that p-value, there's a statistical difference. And again, yes, you can, hypothesize, and if it's a patient you're making a recommendation on, or if you're discussing it, you can see at 1 year it's pretty much set. At 2 years it's a little bit greater. At 3 years, so at 2 years you pretty much get the change, but you can also see a larger sort of growth or disparity there in terms of the effects of the beta blockers versus the non-beta blockers. Any other questions on any of the material? So we've got, a little bit of the history, understanding that chance and bias, we looked at that, the placebo effect. Who funds clinical research? Obviously, pharmaceutical companies with vested interest. Some of the ethics of conducting a research. We've got these 3 tenets, the common rule, the IRB. What's the IRB highly concerned about? Informed consent. You've got experimental studies, you've got descriptive studies, and you've got observational studies. Descriptive, just reporting, whereas experimental or intervening, observational or observing. Single center, multi-center, international studies, benefits and disadvantages, why you randomize, how you randomize, blinding, how you blind, why you blind, different type of controls, placebo-controlled, parallel studies versus crossover studies, why one would be beneficial than another. Outcomes. Again, I don't think I'm going to test this much, but this is one of those very important things when you're actually evaluating the study. Did they look at the right outcome? Why did they choose that outcome? How is that outcome measured? Composite endpoints, subgroup analyses, surrogate measures. Why do we use surrogate measures? They're easy. However, they don't necessarily relate or perfectly correlate with the clinically meaningful endpoint. How long should a study be? Should we publish those clinical trials at the end? If you understand this right here, this slide, in and out, you're beautiful for all of these questions. Understanding what a cohort study is versus a case control study. Why is a cohort study considered better evidence than a case control study? There's one word. What's the one word? Scream it out. Why is a cohort study better than case control? What's the one word?
Perspective.
Prospective. Exactly. Prospective studies, you have more control over what you're doing. You set it up better. You have a question? That's why case reports are very poor evidence. I like how they have meta-analysis here. Sometimes you'll see this pyramid with meta-analysis on the top, and I hate that. Because meta-analysis is either great if it's great individual studies, or meta-analysis is crap if you have one or more studies that are problematic. So your randomized control trials, your experimental studies are your gold standard. Understand how they work. You've got your cohort studies. The Framingham study, just following individuals who live in Framingham over time, we calculate what? The odds or the risk of them developing cancers? The risk, because odds we would be looking back with case control. So the odds of them, so the risk of them developing cancer if they eat broccoli, if they smoke, what the risk of having a heart attack in Framingham. Your case control studies, looking back for rare diseases. Calculates the odds. You have a rare disease. What is the odds that you were exposed to asbestos or broccoli? Case reports, very poor evidence, but they're descriptive. They just tell us what happened, period. Meta-analyses, statistically combining the results of other studies. So here you've got this study, plus 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 this study. That study is different. That study shows a difference. All these others don't show a difference. We add them up. We figure out that providing neonatal or the corticosteroids to women who are delivering babies will have healthier survival. Cross-sectional studies, just a snapshot in time. How many students were in class today? How many of you passed or failed the exam? It's just cross-sectional. It doesn't really tell us anything. A snapshot in time. Allow me to generate hypothesis and maybe do more research. Surveys, N of 1, randomized control or crossover studies in a single patient. We looked at descriptive statistics versus inferential, just describing versus making inferences. Hypothesis versus null hypothesis, type 1 and type 2 error. I would definitely know those on the exam. So if we showed, so type 1, type 2 errors, alpha, beta, methods to increase power, one-tailed versus two-tailed, all of that is great information. Levels of measurement, obviously understanding nominal, ordinal, continuous data sets are essential. Ordinal categories with a distinct rank, so like worse or better, versus continuous is that defined and constant. Normal distribution is one of the basic assumptions for a lot of what we do. And this is what we talked about earlier in the class today. Parametric versus non-parametric. Parametric tests are better than non-parametric tests. Parametric tests, normally distributed, continuous, that's the best type of data, the most inferences that we can make, the best conclusions that we can come to. Probability value, probability of the observed result is due to chance alone, so we want a very small probability value, a very small p-value. We want to know with certainty that it's the drug or it's the intervention. Confidence intervals, you can calculate the range, which you're 95% confident that the true population value will fall. Because we only do one study, we get one number. We don't really know where the true population value will fall, but we can calculate with 95% confidence the range where that will fall. Ideally, we would like a smaller confidence interval because it gives us more certainty. A very wide confidence interval, much less certainty. Then we calculate our relative risk reduction, our absolute risk reduction, our number needed to treat. So this is the one math that may show up in the exam. We'll see how many questions. For those of you who are good at math, would probably want these questions on the exam. For those of you who don't like math, probably wouldn't want these questions on the exam. I don't really care. I'm pretty good at math, so these are easy for me to calculate. But honestly, these are easy to calculate. So you should want these because when you see 6.1 on the exam as a multiple choice question, you know you got it right. If you see 12, 15, 18, and 24, you know you got a problem. You did something wrong. So these are probably would be good questions for you to have. Calculate relative risk reduction, absolute risk reduction, number needed to treat. And then today, understanding descriptive statistics, contingency tables, t-test, non-parametric tests, ANOVA. We didn't really talk about ANCOVA, so you can scratch that off. ANCOVA won't be there. Multiple comparisons, the ANOVA, the Bonferroni, correlation regression, epidemiologic statistics, odds ratio, relative risk, and then the life tables are Kaplan-Meier survival curve and our Cox proportional hazards. So contingency tables, very easy, calculating p-values either through chi-square or Fisher's exact if the numbers are small. If we use students' t-test, we can compare continuous data that's normally distributed. For non-parametric tests, the Mann-Whitney, or the Wilcoxon rank sum, which is essentially ordinal data, or continuous, which is not normally distributed. You've got your ANOVA for your 3 or more groups. We either use a Bonferroni correction or more preferably the post hoc comparisons. ANOVA, ANCOVA, the 2A. We're not going to test this. This is just even higher than I want you to worry about. Relative risk, less than or equal to 1. Odds ratio, less than, equal to, or greater than 1. Correlation, understanding positive correlations and negative correlations. Squaring that gives you a coefficient of determination, which just gives you the amount of variability that can be attributed to the other variable. Regression, different types of ways to predict one variable or score an exam from your other variables. And then life tables, censored and uncensored data. Uncensored data is more complete data. When we censor data, we just don't know if this patient would have died here or if they would have lived for another 12 weeks. But we put that into a Kaplan-Meier survival curve, and we get the probability of living, experiencing event over time. We need the log rank test to provide us a p-value, which will show a difference. Here, there's no difference. Here, there's no difference. Cox proportional hazard, when we take into account a whole bunch of covariates. Here, we can see that there was a difference, both adjusted and unadjusted. The no beta blockers had a higher event rate than beta blockers. As much as that is for you, that's a lot for me as well. It's Monday morning for me. I appreciate you guys hanging in there. Again, I try to keep things simple. If you're confused, try to work it out with each other. Make examples for each other. I think the examples are wonderful. The exam will probably be sort of example-based. It'll be, if I'm comparing drug A versus drug B on an ordinal outcome, which statistical test would I use? Questions like that. If I'm setting up a randomized control studies, what's it better, to have a double-blind, single-blind, or open label in terms of the highest degree of certainty about the extent of causality, that the drug then is having the effect. The double-blind is better than single-blind, which would be better than open label. I will post this as soon as I can today, if not first thing tomorrow morning. Good luck. Enjoy your exams. Every day is getting closer and closer to your PharmD. I promise you that.
Dr. Seaman, how
Yes.
many questions would there be in the exam?
I'm sorry,
How
what
many
was that?
questions?
I'm sorry.
How many questions in the exam, approximately?
The exam's going to be 50 questions.